Good evening. Tonight's discussion, the second in our Fall 2007 presentation series, completes a two-part presentation on optimizing the outcome of patients who have congestive heart failure or who have sustained a heart attack, a myocardial infarction. Last week, we talked about drug and device-based approaches. Tonight, we'll complete our discussion covering nutritional and complementary approaches to heart failure and post-heart attack patient outcome. My name is James Roberts. I'm board certified in internal medicine and in cardiology. I've been practicing invasive and integrative cardiology in Northwest Ohio over the past 21 years. I'm the medical director of comprehensive heart care, the EECP Center of Northwest Ohio, and the Advanced Magnetic Research Institute of Northwest Ohio. Working with my colleagues, Marty Zucker and Stephen Sinatra, I participated in the writing of Reverse Heart Disease Now, a patient manual of integrative cardiology. The principles we talked about last week and tonight are going to be the foundation for a companion book, Reverse Heart Failure Now. Many of the supplements that we talk about tonight, we have included in a nutritional product that we'll talk about next week called Ultimate Cardiofusion, to cover the basis of nutritional supplementation in cardiovascular disease. Really, when we talk about integrative cardiology approaches, we're talking about energy production, endothelial function, oxidative stress, inflammation, and detoxification. And in our approach and in the Ultimate Cardiofusion supplement, we're covering these bases as best we can. More about that next week. The approaches that we talked about last week and tonight are based upon our understanding of the pathophysiology, the causes of coronary disease, heart attack, and heart failure, and the consequences of coronary disease, heart attack, and heart failure. We don't need to memorize anything. We need to understand how things work and why they work. It's not important that any of you remember the details of the studies I present, but I'd like you to open your mind and allow me to try to convince you that these nutritional approaches are of value. So I will present study after study after study to convince you that this is an appropriate course of action for you to take. My approach to the patient with heart failure, I'm going to control your symptoms by removing fluid, volume control using diuretics, water pills, paying attention that I don't wash out potassium, magnesium, and thiamine. We'll use tissue-specific ACE inhibitors that we talked about last week to block vasoconstriction and inflammation, but I'm going to watch to make sure I don't compromise your kidneys or lower your blood pressure, and I need to make room for spironolactone to block inflammation, sodium retention, and magnesium wasting due to aldosterone. And when I'm dosing you with spironolactone, I'm going to watch your kidney chemistries, and I'm going to watch for too high potassium called hyperkalemia. We'll use beta blockers, favoring Coreg or metoprolol to block the adrenergic whip that wants to whip the heart to death. I'll watch to make sure I don't give you too much and make you fatigued, lower your heart rate and blood pressure too much. Pentoxifylline and low-dose statin therapy to block inflammatory mediators. We talked about tumor necrosis factor alpha and free radical generation. External counterpulsation, dual chamber pacing in selected patients, and magnetic molecular energizer therapy is awfully effective in heart failure, as we discussed. But we're also going to use not just drugs and devices, but nutritional interventions. All my patients are advised to take a broad spectrum 6-a-day vitamin and mineral supplement, essential fatty acids, bioenergetic support with coenzyme Q, carnitine, ribose, and magnesium to make ATP our energy source, taurine, which upregulates nitric oxide synthase and helps you retain magnesium, vitamin D if your levels are low, testosterone in men if your levels are low, and detoxification, because toxicity plays a role in all forms of heart disease, chelation, homeopathy, the foot bath, far-infrared sauna, MME, etc. Now, we talked about drugs and devices last week, beginning with digoxin and ending with MME. Tonight we'll talk about the nutritional approaches, coenzyme Q, carnitine, ribose, taurine, antioxidants, fish oil, arginine, testosterone, vitamin D. We'll talk about heavy metal detoxification within the framework of the TAC study that many of you are participating in. The goal of cardiology, be it complementary, alternative, surgical, interventional, is to increase the content of ATP in the cells of your heart. and the ability of your heart to regenerate ATP on its own, because ATP, adenosine triphosphate, is the only source of energy that our heart or any organ in our body can utilize. The struggle for survival is the struggle to make and regenerate ATP. Because we need the heart needs not just enough ATP to contract and relax, it needs enough to contract, relax, and repair itself, carry out homeostatic measures, pump oxygen in, carbon dioxide out. A high ATP is the driving force behind all useful chemical reactions in the heart. If you have a lot of ATP, you're going to do well. If your heart is starved of ATP, you're going to die of heart failure. Our body regenerates ATP in a process called oxidative phosphorylation, which is oxygen-dependent and highly efficient. In the absence of oxygen, we struggle to regenerate ATP with anaerobic metabolism called glycolysis. And then if we have to make the ATP again from scratch, that's a disaster. It'll take 100 days to remake all the ATP in your heart. So we would like to burn sugar and fat in the presence of oxygen. That is the efficient way to regenerate our ATP energy stores. So to regenerate ATP, what do we need? We need oxygen. So if your arteries are blocked, you don't have enough oxygen, you can't make ATP. But it's not just oxygen we need. We need oxygen and the cofactors that the cell needs to burn sugar and fat in the presence of oxygen to make energy. We need coenzyme Q-10, L-carnitine, magnesium, and adenine nucleotides, something to phosphorylate to make ATP. So let's talk about coenzyme Q-10. It is a fat-soluble vitamin with a structure similar to that of vitamin K. It plays many roles. Mother Nature is very economical. She never assigns one role to a molecule. It stabilizes the cell membranes. It's a very important antioxidant. It'll scavenge free radicals. It'll inactivate superoxide. It actually stimulates the production of the enzyme superoxide dismutase, which we'll talk about in a little bit. It regenerates spent vitamin E. So it's a strong antioxidant, but we're going to be talking about its role as an electron transporter. It's critical in ATP regeneration. Now, we burn sugar and fat to generate energy. We snip the carbon chains down to 2 carbon fragments, and then what we do is we snatch electrons from the carbon, and we're going to convert the energy of the carbon-electron bond into useful biochemical energy, ATP. And to do that, we have to transport the electrons on something called the electron transport chain. 2 steps in electron transport involve CoQ. To make energy, you have to have coenzyme Q. No coenzyme Q, you can't make energy. You're going to be dead in 30 seconds. Energy-intensive organs like the heart, brain, kidney, and liver need a lot of coenzyme Q. Coenzyme Q deficiency will affect those organs. The overworked, the chronically strained, or the oxygen-deprived heart will run out of coenzyme Q. Mother Nature didn't design us to be good heart patients. We can't make extra coenzyme Q just because we need it. So the heart under strain runs low in coenzyme Q, then it can't make energy and it fails further. If we look at blood or heart muscle coenzyme Q levels in normal people, people with class 2 heart failure, class 3 and 4 heart failure, the worse the heart failure, the less coenzyme Q. Class 4 is somebody with symptoms at rest. They have a 1-year mortality of 50%. Class 1 is you can play tennis. Class 2 and 3 are in between. The higher your functional class, the worse you are. The higher your functional class, the less coenzyme Q you have in your heart and in your blood. Patients with coronary disease who are subjected to recurrent oxygen deficiency run out of coenzyme Q. If we look at coenzyme Q levels in heart patients, it's 0.8. In healthy people, it's 2.5. We need coenzyme Q to keep our LDL cholesterol from being oxidized. If we're low in CoQ, the LDL becomes oxidized, layers out in plaque. Patients have higher LDL to coenzyme Q ratios than healthy people. The strained heart, the oxygen-deprived heart, will be low in CoQ. A disaster because they need it more than healthy people. Numerous randomized double-blind studies published in the cardiology literature supports the use of coenzyme Q in all forms of coronary disease, angina, heart failure, improving outcome after bypass, and in diseases of the brain, such as Parkinson, or the kidney. All energy-intensive organs need a lot of CoQ, so we're not surprised that it helps not just the heart, but the brain and the kidney. Now, let's look at one of the studies that came out in 1991, Coenzyme Q and heart failure. We're going to look at 180 patients with class 4 heart failure. That is, they're having symptoms at rest due, in these patients, some of them had Cornea disease, some had non-coronary dilated cardiomyopathy, punk hearts. There is a sick group. They had at least 2 admissions per year. Their ejection fraction was 20%. The ejection fraction is the percentage of blood your heart ejects with each beat. If your heart fills with 100 cc's, it ejects 50 cc's, that's an ejection fraction of 50%, that's normal. These people, their heart filled with 100 cc's and they're ejecting only 20%. Pump dysfunction. And they were not doing well with standard therapy. So you evaluate them and randomize them to receive ongoing continued medical therapy or continued medical therapy plus CoQ 100 milligrams a day. You're going to follow them for 8 years. Now, in the usual therapy group, there was no symptomatic improvement, no significant changes in heart rate and ejection fraction. Decompensation and death was predicted by a drop in their coenzyme Q level. So as they went downhill, they lost more and more CoQ. It was a harbinger of ATP deficiency and death. In the supplemented group, their level rose from 0.7 to 2.1 in 2 months. You want a CoQ level of 2. At their 1-year check, their heart rate had fallen by 9%. Their ejection fraction increased from 21 to 38%. The heart rate fell because the heart didn't need to beat as hard, it was more efficient. 78% improved in terms of ejection fraction or functional class. 11 of the 90 improved after 2 weeks. The average response time was 40 days. Drugs work quick. Nutritional intervention works slowly. We must be patient. 1-year survival in the control group, drug therapy alone, was 54%, which is what we would expect. 1-year survival in the CoQ group is 73%. At 5 years, only 1 of the control patients were alive. 47% of the CoQ patients were alive. Many survived 8 years out. This was the first time mortality in heart failure had been shown to be affected. At this point, we did not have any drugs that lowered mortality in heart failure, but we had coenzyme Q. Well, modern day doctors say, well, yeah, coenzyme Q worked 20 years ago, but now we've got modern day drugs with all of our wonderful treatments and stents and angioplasties. Coenzyme Q can't help now. So let's take a modern day study. Patients in whom modern day drug therapy had failed. These are people on the waiting list for a heart transplant. Nothing more could be done for them by their doctors. 25 had Cornea disease as the cause of their heart failure, 7 had a dilated cardiomyopathy, and they're on as much modern day drug therapy as they could tolerate. You evaluate them and randomize them to receive coenzyme Q, 60 milligrams a day in a fat-soluble form, or placebo, reevaluate at 3 months. Double-blind protocol, neither the subjects nor the researchers knew who was getting placebo, who was getting CoQ. Now, the coenzyme Q levels were low at like 0.2. That's disastrously low. You want a level of 2.0. With supplementation, they got up to 0.83. That's not really adequate, but it's a lot better than 0.2. So they gave them CoQ. They didn't give them as much as I would have given. There was no effect on ejection fraction, TNF alpha, which is an inflammatory marker, or the atrial natriuretic factor, which is kind of like the B natriuretic peptide we talked about last week. So the ejection fraction didn't go up, but their symptoms got better. Nocturia is getting up in the middle of the night temp to your bladder because you're reabsorbing edema fluid back into the chest. That worsened with placebo therapy, it decreased with CoQ. Fatigue got better, effort dyspnea, shortness of breath got better, it worsened with placebo therapy. New York Heart Association functional class, remember, 1 is good, 4 is terrible. It improved. Now, these are people who were on the waiting list for heart transplantation. Nobody could do anything for them. You give them CoQ and they get better and they could walk farther in 6 minutes. So before modern day drug therapy, CoQ worked. People who have failed modern day drug therapy on the waiting list for a transplant, CoQ worked, and everybody in between, CoQ works. Here's a study looking at the effect on our hemodynamics in heart failure. 22 patients with advanced heart failure. Their average ejection fraction is 26%. Remember, normal's 50. Their left ventricles were dilated, and they had had stable readings, and you do a right heart catheterization. Remember we talked about if I don't know whether you're wet or dry, I'll do a right heart cath going through the vein in the groin. I put the catheter into the heart, measure the blood pressures within the heart. That's the gold standard, really, in the diagnosis of heart failure. You do the right heart cath and look at the values at rest and during exercise. because your heart is not in good shape, the blood pressure within your heart's going to rise with exercise. That's what makes you short of breath. So you do the baseline studies, randomize them to receive CoQ in oil, 100 milligrams twice a day, or a placebo. You reevaluate at 3 months, double-blind protocols followed. The coenzyme Q level rose to 3.3. That's pretty good. There was no significant difference, though, between placebo and CoQ in ejection fraction, blood pressure, heart rate, or New York Heart Association functional class. However, the stroke index, which is a measure of the pump function, didn't change with placebo. It rose with CoQ. The pump function at rest improved, and during exercise it improved. The pulmonary capillary wedge pressure is the blood pressure your lung sees. Mine is probably somewhere between 5 and 10. These people had heart failure, blood is damming up behind their heart and their lungs, making them short of breath. Their wedge pressure, as we call it, was high at 16. Placebo therapy did nothing. Coenzyme Q lowered it from 17 to 13. The filling pressure, the wedge pressure, rises with physical activity. That's why you're short of breath with physical activity if you have heart failure. Placebo therapy had no effect on the wedge pressure 1 minute and 3 minutes into exercise. CoQ helped. The 1 minute wedge pressure fell from 40 to 32, and at 3 minutes from 42 to 36. Thus, you would be able to do more exercise before you would get short of breath. So their pump function improved, and their diastolic function, the filling characteristics of the heart, improved. So therefore, they could do more, they could walk farther, less shortness of breath. Coenzyme Q admitting rate. 641 Europeans with class 3 or 4 heart failure, so they couldn't go two blocks or 2 flights without being short of breath. Many were short of breath at rest. They're on drug therapy as much as they could tolerate. You randomize them to CoQ, 2 milligrams per kilogram per day, about 150, 200 milligrams, or placebo. You reevaluate, you follow them for a year looking at the effect on admitting rate. Cardiac asthma, which is the European description for admission for congestive heart failure, 40% with placebo therapy, 20% those with CoQ. So 20 out of 100 people that were supposed to have had an admission didn't have it because they took CoQ. Pulmonary edema, which is life-threatening heart failure, 16% placebo, 6% CoQ. New cardiac arrhythmia, 27%, 18%. Hospitalization, 40%, 20%. So we can save a lot of money and a lot of grief in our society if everybody with congestive heart failure took coenzyme Q. Of course, even better than that, if everybody took coenzyme Q, we just have a lot less congestive heart failure, a lot fewer hospital admissions. Statin drugs, because we American physicians will not recommend CoQ. You're not permitted to take coenzyme Q in our hospitals. Instead, what we're going to do is give you statin drugs, the HMG-CoA reductase inhibitors that lower your cholesterol. And they have a role, but they have a downside as well. This CoQ is so important, our body makes it, and we can get it from our diet in fatty foods that we tell you not to eat. But when we take sugar and fat, we break it down into these 2-carbon acetyl groups, and we can burn it, or we can use it to make things. And we can put those carbon molecules together and make things like cholesterol and coenzyme Q. We can make them from scratch, so to speak. However, if you are taking a statin drug, an HMG-CoA reductase inhibitor, lower your cholesterol, you're blocking this step here. So you're blocking the production of CoQ as you block the production of cholesterol. So if you're taking a statin drug, your coenzyme Q levels are going to fall by 50%. So you've got heart disease, and we're going to give you a statin drug, and we're going to take away your CoQ. And I'm telling you that you need CoQ to make energy and to have your heart relax and contract and function normally. So could this be a problem? It is. If we give you a statin drug, we are going to make your heart stiff. We can measure the ability of the heart to relax, its compliance. You want an elastic heart that relaxes well to keep the blood pressures from rising, the wedge pressures making you short of breath. If you take normal people and do cardiac echoes and measure what we call diastolic function, the ability of the heart to relax, it will deteriorate in 71% if you give them a statin. If you keep them on the statin and give them back their CoQ, it will normalize. So if you do take a statin, please take coenzyme Q. You can get the benefits of the drug without the downsides. We call that integrative medicine, and it works rather well. Let's say you had to choose one or the other, CoQ or statin. Let's say you've got an alternative medicine doctor that won't let you take a drug, or you got a straight-laced cardiologist that won't let you take CoQ. If you see me, you're going to take both, but let's say you had to pick one or the other. How are you going to decide? Well, the most important thing we can do in cardiology is improve endothelial function. We talked about that last week. We'll talk about it more. The ability of these cells lining our arteries to make nitric oxide from arginine. That is the key to your outcome. Let's look at 25 patients with endothelial dysfunction. Their arteries are not dilating appropriately. They cannot make nitric oxide. We're going to measure endothelial function and CoQ levels and then treat them in random order with servastatin, a statin, CoQ, or a real intelligent thing, CoQ and the statin, and then reevaluate. CoQ levels fell by 29% in a week. If you take statins, you're going to waste your CoQ, period. Nobody disagrees with that. Flow-mediated vasodilatation, which is the most important predictor of outcome, improved with statin therapy from 4% to 9%. It improved with CoQ monotherapy from 0 to 7%. And if you took both together, it still worked. So we can improve endothelial function with statins. We pay a price wasting CoQ. We can improve endothelial function with CoQ and help you make more energy. We could give you both and get the benefits of statin therapy and CoQ, which is the way that we like to practice medicine. Coenzyme Q and post-heart attack outcome. 144 patients with acute myocardial infarction, heart attack, all hospitalized. All get standard medical therapy, randomized to CoQ in the gel form, 120 milligrams a day or placebo. Evaluate their status at 4 weeks and at 1 year. Randomized double-blind protocol followed. There was no bias here. At 28 days, 28% of the control patients were having angina. That's a bad sign. It means that there's more damage that could be done. Post-heart attack angina is a bad sign. It occurred in 28% of those on standard medical therapy, only 10% of those with standard medical therapy and CoQ. Congestive heart failure falls from 11% to 3%. Low ejection fraction from 23 to 8%. Cardiac arrhythmia from 25 to 10%. Non-fatal heart attack, sudden death, cardiovascular death falls from 13 to 8%. 5 out of 100 people who should have died did not die because they took CoQ. Total event rate at 28 days falls from 31 to 15%. So 16 out of 100 people that would have had an event didn't because they took CoQ. If a drug did that, there'd be ads during the Super Bowl. But CoQ's doing that, and we don't hear about it, which is a shame. Event rate at 1 year, non-fatal heart attack falls from 23 to 14%. Fatal heart attack, sudden death falls. Wow, this is pretty good. What about side effects? CoQ can give some people nausea. Maybe it's one too many pills for your stomach. They had a little bit more emesis, less fatigue because it's good for your skeletal muscles as well. So this is phenomenal. This is better than any drug has ever been shown to do to improve your outcome following a heart attack. Event rate at 1 year, cardiovascular death falls from 20% to 11%, total events from 48% to 25%. Fantastic. Coenzyme Q synergizes with selenium. They work at different steps in our antioxidant defense. Selenium is phenomenal. It blocks different free radicals than does CoQ. There's reason to believe that they would synergize. Let's see. 61 patients with a heart attack. They're coming right into the hospital with chest pain. They all get standard medical therapy. You randomize them to placebo or to a cocktail. The first day they get 500 micrograms of selenium, 100 of CoQ within 6 hours. Then they get a cocktail of nutrients every day for a year, including selenium 100, CoQ 100. Follow them for a year, double-blind protocol followed. The QT interval is an EKG sign of autonomic instability. It predisposes to fatal arrhythmias. We don't like to see the QT prolong. It prolonged a lot more in the controls than in the treatment group. This was a Swedish study, and they used the term verum for treatment. 1 year mortality in the placebo group was 21% from recurrent heart attack. 1 of the 32 patients treated with CoQ and selenium died. 1 year mortality falls from 21% to 3%. Again, no drug could do this. But again, drugs are never smarter than Mother Nature. Mother Nature wants us to take CoQ and selenium to run our physiology correctly. No drug company is smarter than evolution or God or whoever you believe in. So if we work with the rules of Mother Nature, we get better results. Selenium, let's talk about selenium. 21 consecutive patients with heart failure presenting for a cardiac rehab program. Their ejection fraction is 30%, should be 50%. Their 85% are on drug therapy, none on antioxidants. You're going to look at their ejection fraction. Peak VO2, which is how much oxygen you can consume, which is the best marker of your metabolic fitness, your aerobic capacity. Dietary consumption of specific antioxidants, blood levels of antioxidants, and you're going to correlate their antioxidant status with the presence or absence of heart failure, their ejection fraction, and their peak oxygen uptake. Now, the controls, healthy people, their selenium level was 78. It's 63 in the heart failure patients. That was significant. The heart failure patients have a little bit less zinc. They have a lot less vitamin C, less beta carotene. Oxidative stress is burning up their antioxidants. They took in more copper, and copper tends to be a pro-oxidant in heart failure, and they had higher ferritin levels, stored iron, and iron rusts us biochemically. Copper and iron are not necessarily our friends if we have cardiovascular disease. Dietary intake, the heart failure patients took in a lot less selenium, 64 mics per day, as opposed to the controls, and they took in actually a little bit less copper. So the heart failure patients are taking in less selenium than the healthy people. Now, here we're going to look, there's a correlation between dietary selenium, increasing dietary selenium, and the serum selenium. Same thing with vitamin C. The more C you took in, the greater is your blood level. But on two different levels, the normal people had higher vitamin C levels in their blood for any given vitamin C intake than the heart failure patients, because the vitamin C was being used up by the free radical stress generated by the heart failure. Heart failure causes free radical stress, and you use up your vitamin C. Here, we're going to look at the relationship between your serum selenium level and your peak oxygen uptake, which is a measure of your functional status, your aerobic fitness and condition, and it was a direct correlation. So heart failure is associated with oxidative stress, free radical inflammation. It uses up your antioxidants, especially vitamin C. It appears that selenium is critical in preventing this phenomenon. People who had heart failure had less selenium intake, lower selenium levels. Selenium appears to be quite protective in the situation of heart failure. Dietary selenium was positively associated with functional status. Everybody with heart failure ought to be on a lot of selenium. Now, routes to generate cellular energy. The brain prefers oxygen. The heart and our exercising skeletal muscles prefers to burn fatty acids. So how are we going to burn these fatty acids to generate energy? We talked about the importance of CoQ in electron transport, but that's all being carried out in the mitochondria, the cell furnace. We've got to get these fatty acids into the mitochondria so we can burn them. Now the fatty acids are in our blood. It'll enter the cell, cross the cell wall, get in the cell fluid, but the fatty acids cannot get into the mitochondria by themselves. They have to be ferried in by carnitine. This is called the Carnitine Shuttle. The fatty acid binds to carnitine to form the fatty acid carnitine complex, which enters the mitochondria, the cell furnace. The fatty acid and carnitine are split. Then we can start to break down the fatty acids into 2-carbon groups, strip off the electrons, use coenzyme Q to generate energy. Now, in oxygen deficiency, we can't burn these 2-carbon groups. We can't burn acetyl-CoA. And what happens is the levels of acetyl-CoA rise, and the ratio of acetyl-CoA to free-CoA rises. Mother Nature governs her physiology via ratios. Now, when the acetyl-CoA to free-CoA ratio rises, showing that you can't burn these acetyl groups anymore in the presence of oxygen, Mother Nature decides to turn off all the enzymes that we would use to burn sugar and fat in the presence of oxygen. If there's no oxygen, why should you waste energy on enzymes that don't work? And then she turns on the enzymes of anaerobic metabolism, glycolysis. These will try to ferment glucose in the absence of oxygen to make a little bit of energy, but not much, maybe 1/20th as much. This is a fallback mechanism that Mother Nature gives us to keep us from dying if we fall into a lake and have trouble swimming to the surface, or maybe if we run from Marathon to Sparta. It is an emergency backup mechanism. It's very inefficient. It's the last thing we want to do. We would love to stay aerobic and burn sugar and fat in the presence of oxygen. Well, as it turns out, Mother Nature designed us to be efficient cavemen and survive falling into a lake. She did not anticipate that we would have heart disease or carotid disease, and that there would be certain regions within certain organs that are deprived of oxygen or relatively deprived of oxygen. So this switch from high yield oxygen dependent to low yield oxygen independent metabolism is set too tightly. So even if there's some oxygen left, our body shuts off the oxygen utilizing enzymes, shifts into the oxygen independent enzymes function, and the switch is this ratio of acetyl-CoA to CoA. So there's some oxygen there, but we can't use it because of this switch. Now, carnitine will bind to fatty acids. It'll bind to acetyl groups. If there's a lot of carnitine in the cell, what'll happen is the acetyl-CoA will download the acetyl group to carnitine to make acetylcarnitine, free up CoA, the acetyl-CoA to CoA ratio falls back to normal, and the enzymes that use oxygen to burn sugar and fat are turned back on. So in a low oxygen environment, which is your heart if you have coronary disease, you can stay aerobic longer. You can make better use of the oxygen available to you if you have carnitine. And this will translate to survival if you're having a heart attack or maybe walking a minute or two longer on the treadmill. The problem is the people who need carnitine the most have the least. Like CoQ, carnitine is going to be washed out of the stressed heart, the heart failure, the cardiomyopathy, or the coronary disease heart. If we do heart muscle biopsies, look at carnitine, the worse your heart, the lower your ejection fraction, the less carnitine is available. Carnitine stores are reduced 50% in cardiomyopathy, 80% in acute cardiac syndromes. Carnitine stores are reduced in chronic coronary disease. They're extremely low in heart muscle involved in a heart attack. It's all washed out. So the people who need carnitine the most have the least. So let's see if we're going to supplement you with carnitine. Will we improve your metabolic function so you can make more to ATP? Absolutely. Multiple randomized double-blind studies show carnitine to be of value in all important cardiovascular syndromes. Coronary disease, post-bypass outcome, heart failure, cardiomyopathy, claudication, cardiogenic shock, etc. Here's a study of carnitine and heart failure. 900 milligrams a day of carnitine versus placebo over 2 months in patients with heart failure. 55% improved by at least one functional class. Ejection fraction rises in 44%. Effort dyspnea, shortness of breath with effort, is relieved in 44%. Ankle swelling resolves in 33%. Overall, 2/3 improve. Another study, 500 milligrams a day of propionyl carnitine. Propionic acid also plays a role in our metabolism. So in Europe, they bound propionic acid to carnitine and they use it as a drug. 500 of propionyl carnitine versus placebo over 6 months in patients with mild to moderate heart failure. Ejection fraction rose by 8%, from 41 to 45% at 30 days and to 47% at 90 days. Treadmill time increased by 16% at 30 days, by 26% at 180 days, from 7.6 to 9.6 minutes. That is huge. We're not opening up your arteries, but we're allowing you to use the oxygen you have more efficiently, giving you more miles per gallon, so to speak, more ATP per oxygen molecule available. Carnitine in cardiomyopathy, study done in Italy. 70 patients with advanced cardiomyopathy, not due to coronary disease, they had dilated cardiomyopathies. In functional class 3 or 4, they're all on standard drug therapy with diuretics, digoxin, ACE inhibitors, not an antiarrhythmic drug. Randomize them to get 2,000 milligrams of carnitine per day or placebo. You're going to follow them for 3 years. Atrial fib flutter, a cardiac arrhythmia. We don't like to see that in our heart failure patients. It leads to decompensation. Then we need to put you on Coumadin. That occurred in 21% of those on placebo therapy and in only 2% of those on carnitine. So it protected against cardiac arrhythmia. 3-year death rate was 16% with placebo therapy, 2% with carnitine. Wow. Drugs can't do this, but helping Mother Nature do what she intends to do will do this. Let's look at post-heart attack outcome in carnitine. 160 consecutive patients discharged from the hospital following a heart attack. At hospital discharge, randomized them to receive over 12 months, 4 grams a day of carnitine or placebo, otherwise the same care. You reevaluate them at 12 months. In the carnitine patients, as opposed to the colleagues on placebo therapy, lower heart rate, blood pressure, cholesterol, angina arrhythmia is less frequent, a 1.2% mortality. One person died of a blood clot versus 12.5% mortality in placebo therapy. So 1-year mortality falls from 12.5% to 1%. Wow, fantastic. Study of carnitine given intravenously in the emergency room in people with acute heart attacks. The number of PVCs per hour, in the controls it's blue, carnitines it's red. They decrease from the first day to the second day, but there were fewer PVCs in the carnitine group. Couplets per 24 hours was less, repetitive arrhythmia was less in the carnitine group. Episodes of ventricular tachycardia were not less, but hours of ventricular tachycardia, that's a rapid, life-threatening arrhythmia. So there was an acute antiarrhythmic effect when carnitine is given to people with a heart attack. Because they're having smaller heart attacks, they're able to generate more energy, they're going to have less irritability. When you have a heart attack, we don't want to see your heart enlarge, we don't want to see an aneurysm form. If the heart attack expands to form an aneurysm, then the heart segments are not going to be pumping in synchrony. Those are the people we would put in the dual chamber pacemaker. We don't want to see infarct expansion. Here we're going to take 472 patients with a heart attack involved with the front of the heart, randomize them to get 6 grams a day of carnitine or placebo for a year. We're going to do cardiac echoes in the emergency room and at hospital discharge, then every 3 months for a year. Here we're going to look at the diastolic volume, the systolic volume. The diastolic is when the heart is relaxed, systolic volume is when it's contracting. Now in both groups, there was some chamber enlargement due to the heart attack. And over time, their hearts dilated further. But here's the carnitine people, here's the placebo people. The patients on carnitine, their hearts did not dilate as much. So there was a benefit there. Another study of carnitine post-heart attack outcome. 101 consecutive patients admitted to the coronary care unit with suspected heart attack. 80% did have a heart attack, 20% had an acute coronary syndrome. All get standard medical therapy, randomize them to carnitine 2 grams a day or placebo, evaluate their status at 28 days, double-blind protocols followed. Lipid peroxides were less. Those are markers of free radical stress. You made less free radicals because you had smaller heart attacks. When you were able to stay aerobic longer, you didn't make as many free radicals, so your free radical burden falls. LDH and CK are released from the heart cells when they're dying. We don't like to see the LDH and the CK levels go high. The LDH release and the CK release were much less in the carnitine patients. We can do a QRS score, sum up the abnormalities on your EKG. A large QS score means you had a larger heart attack. They were smaller. So by the EKG and the biochemical criteria, these people were having smaller heart attacks, and indeed they were, because heart muscle was being saved because you could stay with high yield, high efficiency, oxygen dependent energy production longer. It saves heart muscle. What effect will it have on outcome? Post-heart attack angina, a bad sign, falls from 36% to 18%. Heart failure, low ejection fraction arrhythmia. Very similar to the stats on CoQ, isn't it? Because they're working hand in hand. Non-fatal heart attack, cardiovascular death, total events, significantly less with carnitine. Carnitine works in heart attack. CoQ works in heart attack. What about putting them together? We don't have any studies of using both agents in acute heart attack in humans. We have plenty of animal studies. We know that in humans, CoQ improves cardiac function, reduces symptoms in angina, heart failure, hastens recovery from bypass, reduces damage in experimental heart attack. Carnitine does the same. Here's a study of laboratory rats where you will ligate one of their coronary arteries and create a heart attack. If you do not give them CoQ or carnitine, it takes 60 minutes for their heart to recover to 80% of baseline. ATP production is markedly reduced. If you pre-treat with carnitine or CoQ, more rapid and full recovery, less reduction of ATP. If you load them up with CoQ and carnitine before the experimental heart attack, the recovery is rapid and complete, no reduction in ATP. And you would predict that that would hold true in humans. We're giving you CoQ and carnitine to help you make ATP, the only source of energy that the heart can use. We have ADP, adenosine diphosphate, and we're going to tack on the third phosphate, and then we wanted to do work, we're going to split this high energy phosphate bond, and that energy that is released will be used by the cell to do work. Then we're going to burn some sugar and fat, use that energy to tack the third phosphate back on. Each molecule of ATP is recycled 10 million times a day. So we can regenerate ATP rapidly in the mitochondria if we've got CoQ, oxygen, and carnitine. In an anaerobic situation, when oxygen's not available, or when you're swimming to the surface of the lake, or you're running away from a saber-toothed tiger and you go anaerobic and get muscle cramps, we do not do a very good job of regenerating the ATP, which is why, if you hold your breath for so long, you're going to pass out. Now, if we are unable to regenerate our ATP and we burn it all off, and I'll talk about that in a minute, and we have to make these adenine nucleotides from scratch, that is a disaster. We're not designed to do that. It's very, very slow and very expensive. To make a new molecule of ATP from scratch, you have to burn 9 ATPs. To regenerate all the ATP in your heart would take you 100 days. That's a disaster. We would like to avoid it. And we should be able to avoid it because ATP is a renewable energy source. When oxygen, calories, and cofactors are available, we have ATP. We want to do work. So we split one phosphate off ATP to make ADP, adenosine diphosphate. Then we burn some sugar and fat in the presence of oxygen, use that energy to tack a phosphate to ADP to make more ATP. We do that 10 million times a day for each ATP particle. Now, when oxygen is not available, as in heart disease or sprinting, anaerobic exercise, we want to do some work, so we split ATP into ADP and phosphate. But then, because we have no energy, because we're not burning sugar and fat aerobically, we can't rephosphorylate ADP to make ATP. We do have an emergency reserve storehouse of high energy phosphate bonds called phosphocreatine. And phosphocreatine can download a phosphate to ADP to make ATP. But we have only 20 seconds of phosphocreatine. We have 10 seconds of ATP. So now at 30 seconds, we're out of energy. So what are we going to do? There's still a little bit of energy in the adenosine diphosphate. There's still 2 more high energy phosphate bonds. So what we'll do, we'll combine 2 ADPs to make 1 ATP and 1 AMP. And then we'll use that ATP. Then we're down to AMP, and there's a little bit of energy left in that last phosphate bond. We'll burn AMP to adenosine and phosphate. And then we're gone, we're lost. And the adenosine will leave the cell. ATP, ADP, and AMP are charged. They will not leave the heart cells, but the adenosine will wash out and be gone forever. But let's say all of a sudden we revascularize you. You come to the hospital, you're having a heart attack, you've burned off all the adenine nucleotides in that section of the heart. We open you up with a balloon angioplasty. So, okay, you got oxygen again. Well, we're going to start burning sugar and fat, oxidative phosphorylation, and we're going to add more phosphate groups to our ADP and our AMP to make ATP. But the problem is we burned off all the adenosine. We have nothing more to phosphorylate. This is called stunning. The heart may not be dead, but you've washed out all the adenine nucleotides due to prolonged and recurrent ischemia, and you cannot make energy. No matter all the oxygen you have, you've got nothing to phosphorylate. So that's a problem. Here, let's look at the amount of ATP. This could be in the heart, it could be in a cell in a petri dish, or a section of the heart that is deprived of oxygen from a heart attack. Over time, the ATP levels will fall. You're burning it all off. Now, the ADP levels will rise at first because you can't rephosphorylate it to ATP, but then the 2 ADP split to form an ATP and AMP, so the ADP levels wash out. the AMP rises and it falls. Here the inset is the percentage of the total adenine nucleotide pool that was burned down to adenosine to leave the cell, never to return. It'll be permanently lost. Okay, so you're going to lose your adenine nucleotide pool from the heart in response to oxygen deficiency. But let's say we revascularize you. We give you a clot-busting agent or a stent. Or maybe this is occurring in a heart that is undergoing open heart surgery and it's temporarily deprived of oxygen. The surgeon finishes, turns the heart back on, the heart's getting all this oxygenated blood. Okay, this is great, we can start making ATP again. But the problem is we don't have anything to phosphorylate. Here, if we deprive the heart of oxygen for 1 hour and then reoxygenate it, it takes a while to start making ATP again, and we're not back up, we only make 80% of normal. The 20% loss is the percentage of the adenine nucleotide pool that was lost. If we go for 3 hours, it takes longer to get back up to steady state and it's lower. The longer you've gone without oxygen, the more adenine nucleotides have been lost, the lower will be your new steady state of ATP because you don't have the precursors. Well, all right, we're going to have to make these new precursors. We're going to make AMP from scratch, but the body was not designed to do that. The building block is ribose. It's a 5-carbon sugar, which we do not get in our diet. Our body can make ribose, but it's very, very, very slow. So this is why if you have this stunning, you may be in heart failure for weeks. You may be struggling on the ventilator because you cannot make any energy. Because it takes a long time for the body to make ribose because we weren't designed to be good heart patients. But Mother Nature gave us a break. It turns out if we can get ribose, this basic building block that is in short supply, into your heart cells, and we can orally or intravenously, the ribose will bind to the phosphate groups and instantly form the AMP. Now you have a building block that you can phosphorylate. So if we can get ribose into your cells, you can make AMP, and the minute you have a return of oxygen, you can start using that oxygen to make more ATP. This will unstun you. So we would predict that ribose would be of value in people with any sort of cardiac crisis, coronary disease, heart attack, post-open heart surgery, or bypass. Let's take an animal model. We're going to take a dog and put them on the bubble pump oxygenator so the rest of their body is being artificially supplied. We're going to choke off the oxygen supply to their heart for 20 minutes. 20 minutes is not long enough to kill the cells, but during that period of oxygen deficiency, all the ATP is going to be burned off to adenosine. So you reoxygenate, but you can't make ATP. So 24 hours later, they're still losing ATP. But if you treat them with ribose, giving them AMP and then something to phosphorylate, they can get back in the ATP generating business immediately. So their recovery from the ischemic insult will be enhanced. What does this have to do with humans? Consider open heart surgery. You know, when you have on-pump open heart surgery, your heart is deprived of oxygen while the surgeon's working. And the reason the heart doesn't die is because the heart is arrested, so it doesn't need as much oxygen, and it's iced. It's put on ice. Still, while the heart cells don't die, they will burn off all their ATP. So the surgeon finishes his bypass, he starts the heart's got all this wonderful oxygenated blood, but it can't do anything with it because it doesn't have any adenine nucleotides. Well, what if we treated you with IV ribose when you're having your open heart surgery? In this study, they looked at 20 subjects with pump dysfunction undergoing bypass or aortic valve replacement, and at the time of surgery, they put them on an infusion of dextrose or dextrose with ribose. And they're going to all have surgery. They all survive the surgery. You're going to look at their ejection fraction a week out. Now, most people's ejection fraction is faltering a week out from surgery because they haven't had enough time to make their adenine nucleotide pool. 80% of the control patients, their ejection fraction remained 15% below baseline. They're going to be struggling. Those that got ribose, only 20% still had a reduction in ejection fraction. They're going to do a lot better. So we can improve your outcome in our treatments of coronary disease or your tolerance to oxygen deficiency if we give you ribose. What about in heart failure? 15 subjects with heart failure, mean ejection fraction is 47%, randomized to receive for 3 weeks ribose 5 grams 3 times a day, that's 1 scoop in water 3 times a day, or placebo. And it's a double-blind protocol. Atrial velocity, time integral, and left atrial volume changed significantly with ribose. The left atrium was smaller because the left atrial pressure was lower because the left ventricle was less stiff. Your pulmonary capillary wedge pressure will be lower. You'll be able to do a lot more. It takes energy for the heart to relax. By giving them ribose, they could make more energy, their heart could relax, less shortness of breath. Symptoms of heart failure were reduced. Quality of life was significantly improved in the ribose group, but not with placebo. Similar studies have been done on patients with coronary disease. You can walk farther on the treadmill if we give you ribose. So I recommend ribose to all my patients with coronary disease and heart failure. Taurine is an amino acid. 62 patients with advanced heart failure on drug therapy, randomized them to placebo or taurine 6 grams a day, double-blind protocol. There was no significant changes in many of these parameters, any of the parameters with placebo therapy, but with taurine, shortness of breath, palpitations, crackles, edema, heart size, New York Heart Association functional class, all improved when you added taurine to drug therapy. Functional class improved in 28% of those on taurine, only 10% of those on placebo. Physician assessment improved. So adding taurine to conventional therapy improves symptoms, signs, physician assessment, functional class in patients with heart failure. Well, why should taurine work? Well, taurine is the most abundant free amino acid in the heart muscle. It's concentrated from plasma into the heart at a ratio of 200 to 1. So it's obviously pretty important to the heart. It has a positive inotropic effect. It helps the heart squeeze with greater vigor. It enhances the positive inotropic effect of digitalis. We talked about digitalis last week. It causes the heart to contract with greater vigor. Taurine enhances that. At the same time, it will protect the heart from toxicity due to high levels of digitalis or adrenaline. Taurine is sort of a buffer. It's a calcium modulator. It has a positive effect in the heart that is low in calcium, but it'll also protect the heart from toxicity due to high calcium. It is a buffer for calcium, digitalis, and it's involved in magnesium. If you have no taurine, your heart will not be able to hold on its magnesium. We talked about how important magnesium was last week. We'll talk more about it next week. Taurine helps keep magnesium in the heart. It upregulates endothelial nitric oxide synthase. This is key. The ability of this enzyme, nitric oxide synthase, to convert arginine into nitric oxide is upregulated by taurine. Taurine levels rise in the heart under strain, but they're low in the hypoxic heart. Just like CoQ and carnitine, taurine is washed out from the oxygen-deprived heart of the patient with coronary disease. So let's give people taurine and see what happens. Here, we're going to give you taurine and CoQ in the setting of an acute heart attack. 51 patients with suspected heart attack all get standard medical therapy, randomized to taurine 6 grams a day and CoQ 120 milligrams a day or placebo, reevaluated 4 weeks. Markers of oxidative stress didn't fall significantly with placebo, fell a lot with CoQ and taurine. Vitamin E and vitamin C levels rose. Now, you're not giving vitamin C, but because you're giving taurine and CoQ antioxidants to scavenge and squelch all the free radicals, you're sparing your vitamin E and your vitamin C. Markers of heart attack size, the QRS score, the leakage of CPK and LDH were blunted. They had smaller heart attacks. Complications and event rate, I hope I'm not boring you with all these statistics showing that CoQ and carnitine and selenium and taurine work. Angina falls from 23 to 8%, heart failure, prolonged QT, frequent PVCs. Total complications falls from 81% to 24%, death and reinfarction 31% to 12%. I'd sure want to be taking taurine and CoQ if I had a heart attack. Fish oils. Just over 2,000 men who survived a heart attack in Great Britain, none with a stated dietary preference, all received dietary advice and recommendation for low-fat diet or not a low-fat diet, high cereal or low cereal, fish oil or no advice at all. So there were 8 possible dietary recommendations. Follow them for 2 years. The low-fat dietary advice had no effect. The high-fiber diet had an adverse effect. Those on the high-fiber diet were more likely to die. Those on the high-fish diet did much better than people who did not take in fish. This was the DART study, came out about 20 years ago. If we look at 2-year mortality, those on a low-fat, high-fiber diet without fish, 2-year mortality is 14%. Same diet with fish in the diet or a fish oil gel cap, it's 8%. Across the board, no matter what other components of the diet you followed, if you took in fish oils, you did a lot better. The low-fat diet decreased your risk of dying by 3%. The high-fiber diet increased your risk by 23%. High-fish diet decreased your risk by 29%. Wow. Well, you could say that was a primitive study before our modern-day drug therapy. Let's look at a study that came out, 11,000 patients, 3 months out of a heart attack, and they're all on modern-day drug therapy, the politically correct drugs that we give you in the hospital. Randomize them to E, fish oil, E or fish oil. You follow them for 3.5 years. Now, cholesterol, LDL, and HDL don't change. Triglycerides do fall with fish oils, but that's not how fish oils are helping you. They have many other benefits outside of improving your lipid panel. Total mortality, at 3 months, there was a significant benefit. 1.1 versus 1.6%. At 42 months, 8.4 versus 98%. There were statistically significant reductions in sudden death, coronary mortality, and cardiovascular mortality. So fish oils alone 20 years ago decreased your risk of dying after a heart attack. Adding fish oil to modern drug therapy does the same. And so if you have heart disease, I want to make sure that you're taking fish oils. If not, you might be hospitalized, and I'll do a heart cath on you, and I'll biopsy your heart, and I'll look at it under the microscope, and I hope I see something fishy going on in your heart. There was another study, the Indian experiment of infarct survival. Fish oils had the same beneficial effects, just as you would see with CoQ and carnitine. When you're working with Mother Nature, you get important benefits. Antioxidants and early post-heart attack outcome. The Indian experiment of infarct survival, 125 heart attack patients, randomized them to 4 weeks of treatment with placebo or an antioxidant cocktail. Vitamin C, IV then orally, vitamin A, IV and orally, vitamin E and beta-carotene. All standard therapies were permitted. One group got the antioxidant cocktail, one group got placebo. Why the cocktail? One point I like to make is that our antioxidant defense system is a team defense system. Think of a football team analogy. There are many different sources of free radical stress. Vitamin E will get some but not others. Selenium gets some but not others. C and Q and carnitine get some but not others. Taking a high dose of one antioxidant is stupid. It's like fielding a football team with one all-star and 10 guys with broken legs. The free radicals are going to get you. So Mother Nature planned on a defense team. We want to mimic and support Mother Nature. So it's my job, of course, to coach your antioxidant defense system. So in this study, the Indian experiment of infarct survival, they followed that philosophy and gave you a team approach to antioxidant defenses. Makes a lot of sense. What happened? Vitamin C and vitamin E levels went up. They didn't give you C and E, but because they gave you some C, but because you're squelching free radicals, your other endogenous antioxidants are preserved. Lipid peroxides, the marker of free radical stress, fell because of the antioxidant effect, blocking free radical stress. The release of enzyme CPK, SGOT, LDH was blunted. Their EKGs were less abnormal, so the EKG and the biochemical indices of infarct size, the amount of damage done, were lessened. Event rate at 4 weeks, post-heart attack angina falls from 27 to 16%, reductions in heart failure, low ejection fraction, triplets, complicated arrhythmia, non-fatal heart attack, cardiovascular death, Total events falls from 31 to 21% just by taking antioxidants. Wow. Minerals and post-heart attack outcome. 355 patients hospitalized for acute heart attack, randomized them into 3 groups. One group gets placebo, dextrose in water. Another group gets IV and oral magnesium. Days 1 through 3, they get 5 grams of mag sulfate every day. Then for the next 2 years, they take magnesium hydroxide, 400 to 800 milligrams a day, depending on their weight. Another group gets IV potassium, 10 milliequivalents a day, which is not that much for 3 days, then magnesium. All standard therapies permitted, double-blind protocols followed. Why is magnesium important? Well, we talked about how spironolactone worked last week by retaining magnesium in the cell, and that improved your ejection fraction and protected against arrhythmia. Spironolactone's working, it's doing many things, but it's helping you retain magnesium. Magnesium is critical to the cardiovascular patient. Magnesium has an antiarrhythmic effect. There are no arrhythmias that do not respond to some degree to IV magnesium. It improves endothelial function, the ability to convert arginine to nitric oxide. Magnesium has an anti-inflammatory effect. It lowers CRP. It's critical in energy metabolism, and diuretics waste magnesium. We talked about that last week. The downside of diuretic therapy is wastage of magnesium, potassium, and thiamine. Now, there was a study of people with Cornea disease, and you look at intracellular magnesium. In normal people, it's 38. The Cornea patients, it's 33. Placebo therapy doesn't do anything, but with magnesium supplementation, it rises towards normal. Flow-mediated vasodilatation, endothelial function, that critical parameter, quadrupled with magnesium. Magnesium is certainly important. Magnesium and inflammation, 133 sequential patients presenting to the ER, 68 with heart failure, 65 with other non-cardiac illnesses. The serum magnesium level was lower in the heart failure patients than in the patients with other medical problems. Their C-reactive proteins, that marker of inflammation, were greater. And there was a relationship between magnesium and CRP. The higher your magnesium, the lower your CRP. People with low magnesium, which is most new patients in my practice, have higher CRPs. Magnesium is anti-inflammatory. So, we're going to take 35 heart failure patients with a normal baseline serum magnesium level, all had pump dysfunction, ejection fraction below 40%, randomized to receive mag citrate, 300 milligrams a day or placebo, reassessed at 5 weeks, double-blind protocols followed. The serum magnesium went up a little bit with placebo therapy. It went up more with magnesium in a statistically significant fashion. If we look at intracellular magnesium, it went up in a significant fashion only in the supplemented group. If we look at C-reactive protein, it fell insignificantly. With placebo therapy, it fell a lot more. So people with heart failure are low in magnesium, they're inflamed. We give you magnesium, we blunt the inflammation, and that's very important because C-reactive protein is a bad guy. It is a marker and a mediator of inflammation and oxidative stress. A high CRP is a bad sign. It increases your risk of cornea disease, cardiovascular events, poor outcomes following angioplasty, stent, bypass, etc. Cornea disease is not due to cholesterol. It's due to oxidation and inflammation. We don't like to see oxidation and inflammation. Those are not Mother Nature's plan for us, and magnesium blocks these phenomena. It has an antioxidant, anti-inflammatory effect. If we look at people with stable cornea disease, many of you who are my patients with stable cornea disease, and we look at your C-reactive proteins, and we follow you over time, those of you with levels below 1 do a lot better than those of you with levels of 1 to 3 who do better than those with high levels. Risk of heart failure amongst people with stable cornea disease rises as your CRP rises. So we don't like to see CRP, and we know that magnesium lowers CRP. If you have heart failure, we might treat you with diuretics to get rid of the fluid, right? The problem with diuretics are they will waste electrolytes, potassium, magnesium. Is this a problem or not? 50 consecutive outpatients. This was done in 1988, really before we understood why it's critical to replete your potassium and magnesium. 25 were presenting for minor surgery. the controls, 25 were on chronic diuretic therapy for hypertension or heart failure. 11 on a thiazide, such as hydrochlorothiazide. 14 were on loop diuretics, such as furosemide Lasix. 20 were on potassium supplements, none on magnesium, none on spironolactone. We're going to draw serum levels of potassium, sodium, magnesium. Then we're going to do a muscle biopsy and measure intracellular potassium, sodium, magnesium, and sodium-potassium pump units. Now, the sodium-potassium pump is a key component of the cell membrane. It pumps sodium out and potassium in. And this is critical for normal function of the cell. If your sodium-potassium pump's not working, your cells will swell with sodium, become edematous. You're going to have trouble getting oxygen in and carbon dioxide out. For your sodium-potassium pump to work, you need ATP energy. And to make ATP energy, you need the sodium-potassium pump. They're intertwined. So if one goes bad, the other goes bad, you go downhill in a vicious circle. We want a healthy sodium-potassium pump. We want to pump out the sodium, pump in potassium to allow the inside of the cell to be electrically negative, minus 70 millivolts to the outside. 6 cells, they lose their sodium-potassium pump. The electronegativity within the cell falls off, and they begin to fill with sodium. They don't have enough potassium, and then you go downhill from there. Here's the sodium-potassium pump. You take sodium, it enters the pump, you burn an ATP molecule, you extrude the sodium, you bring the potassium back in. It takes energy to do this, ATP energy, and you have to have this pump to make ATP energy. We don't want to see a fall off in our sodium-potassium pump function. Now, healthy cells have a powerful sodium-potassium pump. They're electrically negative on the inside and the outside. As we lose the sodium-potassium pump, we can't make energy, we become less negative on the inside, and we degenerate in edema, inflammation, oxygen deficiency, and then the cell goes malignant. Now, diuretics waste potassium and magnesium. Is this important? Let's look at the serum levels, not the intracellular, but the serum levels, the blood levels. Those on diuretics, their magnesium level was very similar to that of the controls. There's no real difference there. Their potassium level was a little bit lower, 4.1 versus 4.3, but that was not very important. Their sodium level's not the same. So the diuretics are not really affecting the blood levels of the electrolytes. But if you look at the intracellular levels, where all our physiology is taking place, there was a big difference. Here is the controls, the intracellular magnesium and potassium in the healthy people. In the diuretics, it's a lot lower. Intracellular magnesium was 7.6 versus 9.5, less sodium, less potassium, more sodium. And if you look at the sodium-potassium pump units, this key parameter of our physiology, they were lower in the diuretic group. So diuretics are wasting potassium and magnesium, not reflected in the blood, but within our cells. And when that occurs, the sodium-potassium pump units drop out, and the cell physiology goes downhill. That's why many of you on diuretics, you're tired. And I measure your blood levels of potassium, and it's okay, but I'm not measuring the intracellular, obviously, and that's not okay. So that's a problem with diuretics. Well, that means I have to supplement you aggressively with potassium, magnesium, and that's what I do. Let's get back to our study of minerals and post-heart attack outcome. If intracellular potassium and magnesium is so important, and by the way, you have to have magnesium to keep the potassium in the cells, let's see what effect mineral supplementation is going to have on heart attack survivors. Well, it helped a lot. If we look at 4-week outcome, this is the intravenous and oral magnesium, intravenous potassium and oral magnesium. Here's the controls: non-fatal heart attack, fatal heart attack, arrhythmia, cardiovascular events, death. There was significant reductions. At 4 weeks, 14% in the controls. Those that just got a few dollars worth of potassium and magnesium, 50% reduction in death. Similar findings at 12 months. So if you have a heart attack and we just give you some minerals, we're going to give you tremendous benefits, because we want the intracellular levels to be high. We want your sodium-potassium pumps to function normally. Now, TACT is the trial to assess chelation therapy. We'll talk more about chelation therapy in a few weeks. It's the administration of magnesium EDTA, a molecule that will bind to and remove lead, cadmium, and arsenic from your body. We're going to take 2,400 subjects, all at least 50 years of age, non-smokers, at least 6 months out from their first heart attack, no revascularization within 6 months. All will get standard post-heart attack drug therapy, which we talked about last week, 30 IV treatments over 30 weeks, and 1 treatment a month over 10 weeks, and a multivitamin. You'll be randomized, half get IV chelation, half get IV placebo, half get a high potency multi, half get a low potency multi. So 25% of you will get IV chelation and a strong multi. That's what I would do clinically in open therapy. Some will get IV chelation and a weak multi. Per tonight's discussion, half of the subjects will not get chelation therapy, but 25% will get a 6-a-day vitamin and mineral, antioxidants, minerals, magnesium, potassium, things I'm talking about, and half will get a 1-a-day. And we're going to look at the effect on outcome. And I predict we're going to show that lead and cadmium detoxification improves outcome, and that people that take a 6-a-day multivitamin have a better outcome, as you'd suggest from the studies I've shown you, the antioxidant study and the mineral study. And I think the best outcome will be those that get detoxified and get a high potency mineral. And this we'll know in about 2 to 3 years. Thiamine. Does furosemide Lasix induce thiamine deficiency? It does. Will it aggravate congestive heart failure? Will supplemental thiamine reduce symptoms and improve cardiac performance in our furosemide-treated heart failure patients? Thiamine is a B vitamin that you need to burn sugar to generate energy. Just as you need carnitine to burn fat, you need thiamine to burn sugar. Diuretics waste thiamine. So if you have heart failure, I'm going to give you a bunch of diuretics. I'm going to make you thiamine deficient. And then you're going to have trouble burning sugar. Is this going to have a clinical effect? 30 patients with chronic heart failure, all with advanced disease, ejection fraction below 45%, they're in class 2 to 4, all on at least 80 milligrams a day of furosemide, which is a fairly significant dose for 3 months. You're going to hospitalize all 30 for a week, home meds continued, put them on a hospital diet, give them thiamine, 100 milligrams or placebo intramuscular twice a day for a week. Then you're going to reevaluate as a randomized double-blind study. Then you're going to send them all home on oral thiamine, 200 milligrams a day, plus the usual meds, and reevaluate 6 weeks later. And what you find, thiamine levels were fairly low, 2.6, placebo therapy did nothing, but with thiamine supplementation, the blood thiamine level rises from 4.3 to 90. Urine output did not change significantly with placebo therapy, about 2 liters. Now, if you have heart failure, we want to mobilize that fluid. We want your urine output to increase. Just by giving them thiamine, their urine output per 24 hours increases from 1.7 to 2.4 liters. Sodium excretion increases. Their ejection fraction rises 14% from 28 to 32%. The diuretics have a role to control your symptoms, but they wasted thiamine, so you can't generate energy. We give you back the thiamine, something Mother Nature wants you to have. All of a sudden, your body works better, you're making energy, you can pump out the edema fluid, your ejection fraction rises. Then you send them all home on 2 milligrams a day of thiamine, and their ejection fraction rose 22%. Wow. Endothelial biochemistry. We're talking about the endothelial cells. These are the single layer of cells that line normal, moderately, and severely diseased arteries. Their ability to convert arginine into nitric oxide. The enzyme that does this is nitric oxide synthase. This is the most important determinant of outcome for the patient with coronary artery disease. Now, we spend 2 different talks talking about endothelial function. The endothelial cells, if you scrape them off the walls of your arteries, you'll have a massive tissue the size of the liver. They're basically hormone-producing factories. And key here is the conversion of arginine into nitric oxide. That is the chemical reaction that we would like to stimulate. Now, here's a patient that had a stent placed in his right coronary artery, and here's his left coronary artery. It doesn't look so bad. There's some modest narrowing. You infuse acetylcholine. Acetylcholine is an endothelium-dependent vasodilator. If your endothelium is working well, acetylcholine will dilate the artery. If your endothelium is not working well, if you can't make nitric oxide, it'll vasoconstrict. This man had endothelial dysfunction. He could not make nitric oxide in response to acetylcholine. He went into a spasm, and he would have chest pain. So then they injected nitroglycerin, which is a pharmacologic vasodilator. It gives you nitric oxide as a drug effect, and it dilates you up. And then they sent the guy home. Brought him back 4 years later and repeated his heart cath as part of a study. And you can see where he had the functional spasm, where he had the worst endothelial function in his coronary tree, is where he now had a fixed narrowing. So in this man, endothelial dysfunction predicted disease progression. The site of the most intensive endothelial dysfunction predicted where he would have his fixed blockage. Many studies have been done showing that endothelial function is the best predictor of your outcome. We can look at endothelial function in many different ways, but people with good endothelial function are blessed. They are not going to get into trouble. You can have 80% narrowings and good endothelial function, and you're going to be okay, as opposed to somebody with a 40% narrowing and a shot endothelium who's going to die, period. So endothelial function is critical. Now, when we talk about preventing cardiovascular disease, I talk about identifying all of your risk factors, the conditions associated with an increased risk of cardiovascular disease. Actually, I could relabel this slide causes of endothelial dysfunction, because everything that causes coronary disease does so by compromising the endothelium. We have pages and pages of causes of endothelial dysfunction. Hypertension, smoking, low HDL, depression, sleep apnea, atrial fib. On and on and on we can go. Angioplasty and stents. Radioactive stents blow away the endothelium for a year. So there's many, many causes of endothelial dysfunction. Now, endothelial dysfunction can be attenuated or reversed by risk factor control. Some of the drugs that improve outcome do so by improving endothelial function. Statins improve endothelial function. Exercise, ECP, Dr. Bonley's MME machine, a static magnetic field, improves endothelial function. Nutritional intervention, the nutritionals that improve your outcome all improve endothelial function. And the one that's probably the most important is arginine, because arginine is the raw material that is taken up by the endothelial cells, converted to nitric oxide by the enzyme nitric oxide synthase. So, if we measure flow-mediated brachial artery enlargement, we measure the diameter of the brachial artery in the elbow, we occlude the brachial artery with a blood pressure cuff, we release it. Blood's going to be rushing down the brachial artery. That should cause the brachial artery to dilate if the endothelium is healthy. Now, these are people with high cholesterol, endothelial dysfunction. You're going to measure endothelial function at baseline, and they only dilate 2.3%, and they give them 4 weeks of placebo, nothing happens. Or at baseline, they're 1.7%, and it should be 12%. You give them arginine, 7,000 milligrams 3 times a day, it improves. You are neutralizing the vascular toxicity of high cholesterol with arginine. You're not lowering cholesterol, but you're working deeper in the chain of events. Cholesterol bothers us by causing endothelial dysfunction. By improving endothelial function with arginine, we can neutralize the vascular toxicity of cholesterol and just about everything else that wants to cause heart disease. Arginine improves or restores endothelial function. In coronary patients, that means less angina, less vasospasm. It's effective in unstable angina, refractory angina, improves post-MI outcome in one study, prevents nitrate tolerance and toxicity. In heart failure, ejection fraction, cardiac output functional status improves, symptoms decrease. In patients with lower extremity vascular disease, they can walk farther with fewer symptoms. In experimental atherosclerosis, arginine protects against the initial plaque buildup when you cholesterol overfeed animals. It regresses pre-existent narrowings. It's beneficial in erectile dysfunction. What is erectile dysfunction? It's angina of the pelvic organs. Recommendations to people with known atherosclerosis: 2 to 4 grams of arginine between meals 3 times a day, preferably coupled with cofactors that stimulate the conversion of arginine to nitric oxide. Arginine in heart failure. In patients with heart failure, production of nitric oxide is impaired. They have endothelial dysfunction. Superoxide levels are increased. Superoxide is the free radical that degrades nitric oxide. So you're going to have vasoconstriction in the periphery at rest or with exercise. You won't be able to do as much because blood flow to your muscles has been compromised. The severity of symptoms in heart failure is not related to your ejection fraction, it's related to endothelial function, the ability to dilate arteries in your extremity so you can do more useful work. Could supplemental arginine improve nitric oxide formation, reduce superoxide levels, improve endothelial function and your functional status? 12 patients with advanced heart failure due to coronary disease, ejection fraction below 35%, you're going to give them IV arginine, 20 grams over an hour, and look at systemic vascular resistance. This is the peripheral vasoconstriction. You give them arginine, they make nitric oxide, their arteries without their body dilate, the heart can eject now into a vacuum, cardiac output improves, blood flow to the extremities improves, you can do more. Ejection fraction rose, cardiac output rose with IV arginine. What about oral arginine? That's a lot more practical. 15 patients referred to the University of Pittsburgh for heart transplantation. They're a sorry group of patients, not much more we can do for you. 6-week treatment period with placebo, arginine 9 grams a day, arginine 12 grams a day, and it's a double-blind crossover protocol. Effective arginine on hormone levels. Noradrenaline, the cardiac whip, was lower in the arginine group. Endothelin, which is a vasoconstrictor, the Darth Vader molecule, was lower. Arterial elasticity was better. So it's dilating the arteries and it's blocking some of these hormonal whips. The percent increase in forearm blood flow as a function of how much work your muscles is doing improves. So in response to the need for blood, the heart can come through because you're vasodilating better. How far you could walk in 6 minutes increases from 390 to 422 meters. Your living with heart failure score falls, which is good. So these people who are too far gone for anything but a transplant, you give them arginine, their biochemistry improves, the hormonal whips are abated, and they have a better functional status. Arginine and post-heart attack outcome. 792 patients with a heart attack, randomized to receive over 30 days, arginine 9 grams a day or placebo, all standard therapies permitted, followed them for 6 months. Overall, there wasn't much of a benefit, except in people with prior heart attack and hyperlipidemia, there was a benefit. This was just giving arginine to people with an acute heart attack. Another study, 153 subjects, 3 to 21 days out from a first heart attack, 88% had a stent, greater than 90% on aspirin, Plavix, ACE inhibitors, statins, and beta blockers, but no other nutritionals. And you randomize them to arginine 9 grams a day or placebo, you read out at 6 months, there was no effect on ejection fraction, no effect on vascular elasticity. The event rate was greater in the arginine group, 17 versus 10%, and the death rate was greater. Some died of infection. This has been the only study published that is negative on arginine. There have been hundreds of other studies that were positive. Why was this negative? They gave arginine and arginine alone to patients with a heart attack. Heart attack is associated with free radical stress. The malondialdehyde, the lipid peroxides are high. We can lower that with antioxidants. If you give arginine alone to someone under intensive free radical stress, the nitric oxide you generate will be oxidized to peroxynitrate, which is a flaming coal. And it will promote, you can convert an antioxidant to an oxidant. So giving arginine alone to people under intense free radical stress was a bad idea. Now, I wouldn't have done that because I don't think of nutrition as pharmacology. I understand I'm giving you arginine and I want to convert it to nitric oxide and I want to protect it. Had we done that, they would have had a better outcome. But it just shows if you try to use a nutritional agent like a drug, sometimes you don't get the desired consequence. We need to understand the biochemistry of what we're doing and support it. They gave arginine to people who are making a lot of superoxide. It got oxidized. They didn't get the good result. Their angiotensin converting enzyme is on fire. We talked about that last week. They're making free radicals. So the arginine alone didn't get the job done. It actually made the situation worse. Now, those of us that understand nutritional biochemistry, we're going to say, all right, we're going to give you arginine, but we're going to give you cofactors, C. buckthorn, grapeseed extract, folic acid, B vitamins to stimulate nitric oxide synthase to make nitric oxide. Then we want to protect the nitric oxide we generate from free radical stress with agents such as vitamin C, selenium, CoQ, and C. buckthorn. Ultimate Cardiofusion, the nutritional supplement that I designed that we'll talk about next week, has all this stuff. We want you to be soaking in nitric oxide. And we're going to give you vitamin D, which blocks the neurohumoral cascade. We're going to give you fish oil. We're going to give you everything that we think is helpful. We're going to be practicing nutritional medicine, not trying to use nutritionals as drugs. Vitamin C inhibits endothelial cell apoptosis. Apoptosis, we talked about that last week, is the premature death of a cell suicide. Now, serum from heart failure patients will induce apoptosis in cultured human endothelial cells. There's something toxic in the blood of a heart failure patient that causes normal cells to commit suicide. Apoptotic membrane particles are elevated in heart failure patients. We can measure this in your blood, and we can show that your heart cells are committing suicide in response to these whips. Tumor necrosis factor alpha, C-reactive protein, angiotensin II, we talked about them last week, are all causes of endothelial cell apoptosis or suicide. All these mediators produce oxidative stress. Oxidative stress wastes vitamin C. Vitamin C levels are low in heart failure patients. Could supplemental C blunt the oxidative stress and protect against apoptosis? Could vitamin C neutralize the cell suicide brought on by TNF-alpha, CRP, and angiotensin II? We're going to incubate HUVECs, human umbilical vein vascular endothelial cells, with tumor necrosis factor alpha, with or without vitamin C. If we incubate these normal cells with tumor necrosis factor alpha, they begin to commit suicide. But if we incubate them with the tumor necrosis factor alpha and then give them vitamin C in increasing doses, we protect them. So vitamin C protects the cells from suicide due to the TNF. Same thing with angiotensin II. We talked about how these mediators cause the heart cells to die. They're doing that through oxidative stress, and if you have vitamin C, you can protect against that. Very important. 34 patients with heart failure, mean ejection fraction 26%, they're on standard drug therapy. Now you're going to incubate these human umbilical cord vascular endothelial cells with blood drawn from the heart failure patients at baseline, or blood drawn 15 minutes after a 10-minute infusion of vitamin C or placebo, or following 3 days of oral vitamin C. The serum of the patients, before you give them vitamin C, kills a lot more endothelial cells. But one shot of IV vitamin C reduces the cell suicide rate by 76%. 3 days of oral vitamin C reduces the cell suicide by 82%. So we would predict that vitamin C would protect the heart of the patient with heart failure from premature cell death, cell suicide. We're going to measure the plasma levels of circulating apoptotic endothelial cells. So we can look at the carcasses of the dead endothelial cells. Baseline blood sample, blood drawn after 1 IV or after 3 days. And there was a significant reduction in plasma apoptotic particles. So giving vitamin C to patients with heart failure blunts cell suicide. If your cells aren't committing suicide, they're going to stay in the heart's going to function better, it's going to function longer, you're going to be less likely to die. It also blocks production of free radicals and squelched free radicals. Vitamin C and nitrate tolerance. 20 patients with heart failure, they have high filling pressures within their heart. You're going to give them IV nitroglycerin, which is a pharmacologic source of nitric oxide, with placebo or with vitamin C. Now, vitamin E levels fall with placebo therapy, but not with vitamin C and nitro. When we're giving you exogenous nitric oxide, your body stops making its own, it makes superoxide that will degrade the nitric oxide you do make and the nitric oxide we give you. This is called nitrate tolerance. So when we give you long-acting nitrates, we're causing endothelial dysfunction and we're worsening your outcome. So you're giving them IV nitroglycerin, a steady dose, over 18 hours. You're getting nitrate tolerance, you're getting free radical stress, and you're going to waste your vitamin E. So that is a side effect of these drugs we give you. Now, if we give you the IV nitro and vitamin C to squelch the free radicals, you can hold on to your vitamin E. If we look at platelet cyclic GMP, that is the molecule we want to raise to keep the platelets from sticking. If we give you the nitroglycerin, at 6 hours you're making a lot of it, then you get nitrate tolerance, free radical stress, you make less, your platelets are going to be sticky again. If we give you the nitro and vitamin C, we protect you. Pulmonary capillary wedge pressure, we want your wedge pressure to be 10 to 15. So we're going to give you the nitroglycerin to vasodilate you, and it works. Your wedge pressure falls from 24 to 15, but then you develop nitrate tolerance, it goes back up. If we give you the nitro infusion with vitamin C, you get the benefit. So when we have our patients on long-acting nitrates, we must put them on vitamin C to get the benefit of the drug without the downside. Similar to coenzyme Q with statins. Vitamin C does so many things. We give a 2-hour talk on vitamin C. It stabilizes the circulation, it lowers lipoprotein A, it improves endothelial function. 1,000 milligrams of vitamin C is a must for all patients with cardiovascular disease. What disease does this child have? Rickets, due to vitamin D deficiency. We were taught in medical school that the role of vitamin D is to promote calcium absorption from the gut and make our bones strong, and that was it. And we were taught wrong. Many of the things we learned in medical school were not quite right or were frankly wrong. This is one of them. Now, vitamin D physiology is a little difficult. What happens? The skin will convert cholesterol. The rays of the sun will convert cholesterol in our skin into vitamin D. That is, if we have enough cholesterol. If we take drugs to lower our cholesterol, it doesn't work so well. But the sunlight will convert cholesterol into vitamin D, an inactive form of vitamin D. This inactive form of vitamin D enters the circulation. It goes to the liver, where it is hydroxylated to 25 vitamin D, that goes to the kidney to make 125 vitamin D, where it goes to the gut to promote the absorption of calcium. So we thought if you get some sunshine, if you have a good diet, if your kidneys and liver are okay, that's all you need. And the only role of vitamin D is to keep your bones strong. Well, this is what we were taught, and that was, of course, incomplete. Because every cell in the body has a vitamin D receptor. Vitamin D has multiple direct chemical effects, and it influences DNA transcription. It influences the interpretation or the reading of the genetic code. It's a hormone. Many cells can convert the 25D into the 125D. You don't have to have the kidney to do this. Vitamin D deficiency of any degree will lower your blood calcium. And if you lower your blood calcium just a smidge, the parathyroid hormone, the parathyroid, there's 4 of them in the thyroid in the neck, senses it, and it makes parathyroid hormone, which liberates calcium from our bones. But parathyroid hormone is toxic to the heart and the vasculature. Parathyroid hormone causes apoptosis of the heart and is atherogenic. So we don't want to see a high parathyroid hormone. Instead, we want adequate D to make sure that the calcium is maintained within tight levels. We don't want to see parathyroid hormone because that causes heart disease. The lower your vitamin D level, the higher your parathyroid. What we want to see really is a vitamin D level above 30. A vitamin D level above 30 will suppress parathyroid hormone, which is the goal. Now, the closer you live to the equator, the less cancer you have, the less autoimmune disease. The closer you live to the North Pole, the more cancer you have, the more multiple sclerosis, the more rheumatoid arthritis. Vitamin D is key in immune surveillance. We've been telling you to avoid the sun because of skin cancer, and that's true. If you live in Florida, you have more skin cancer than you have up here, but if you live in Florida, you have fewer serious internal organ cancers because of the vitamin D. Okay? So we don't want you to get skin cancer, but we want to make sure you get enough vitamin D. Now, let's look at the relationship between vitamin D, latitude, and cardiovascular disease. The farther you live from the equator, men and women, the more heart disease you have, because you have less vitamin D. Vitamin D protects against cardiovascular disease. Let's look at a study of vitamin D and coronary risk factors. 1,500 Americans in the NHANES, National Health and Nutrition Education Study, not on vitamin D supplements. We're going to look at their standard risk factors, measure a vitamin D level, and correlate it with the other risk factors. The mean for Americans was 30, which is borderline sufficient. Though the first quartile, the lower 25% bracket, was 21, the fourth quartile was 37, and that's nothing to brag about there. If we look, here's the mean vitamin D level of 30. Those with high blood pressure, it's 27. Those with diabetes, it's 25. Overweight, 26. Proteinuria, which is kidney dysfunction, 26. Your relative risk of having hypertension, if you're in the lowest versus the highest vitamin D level, rises by 30%. You double your risk of diabetes, your risk of obesity rises 2.3-fold, your risk of proteinuria 2.5-fold. Low vitamin D is associated with risk factors for cardiovascular disease. We talked about angiotensin converting enzyme inhibitors to block the conversion of angiotensin 1 to angiotensin 2, and how important that was in the treatment of heart failure and coronary disease. The kidney releases renin that starts this whole neurohumoral cascade. Vitamin D blocks that. So if you got a lot of vitamin D, you'll make less renin, you'll make less angiotensin 2, you'll make less aldosterone, you're going to have less hypertension, less heart failure. We won't need to give you so many of our wonderful drugs if you take vitamin D. Ultimate Cardiofusion, my supplement, supports endothelial function and neurohumoral blockade, so we're going to include vitamin D and we're going to include fish oil. Here's a study of people, vitamin D and blood pressure. Individuals who are randomized to calcium or calcium and D. With calcium alone, the vitamin D level rose insignificantly. That was just by chance. It rose significantly with calcium and D. Parathyroid hormone fell a little bit with calcium. As your blood calcium goes up, the parathyroid falls. It fell a lot more with calcium and D. We want to see a low parathyroid hormone. That's our target. Systolic blood pressure with calcium alone fell from 141 to 135, which is okay. Calcium and D, 144 to 131. Diastolic blood pressure fell with calcium, but calcium and D, it fell more, 85 to 78. Now, if a drug did that, it'd be FDA approved. Vitamin D does that, and it's not. Heart rate fell. Why did your heart rate fall? Because your heart is stronger, your arteries are more elastic, your heart doesn't need to work as hard because your system's more efficient. Vitamin D and congestive heart failure. Everybody with heart failure has low vitamin D levels. I've been measuring this in my practice. Dr. Poling in Monroe has been measuring in his practice. They're all real low. Study of vitamin D levels in congestive heart failure. With calcium alone, nothing happens. It goes up with calcium and D. Tumor necrosis factor, that is an inflammatory mediator that causes cell suicide, falls with vitamin D. Interleukin 10, which is a good guy, it's anti-inflammatory, rises. So people with heart failure are low in D, they're inflamed. Vitamin D is anti-inflammatory. So your biochemistry improves, less oxidative stress, less inflammation. Testosterone is the heart hormone for men. Testosterone has so many benefits for men with cardiovascular disease. It makes your blood less viscous, it decreases your risk of clotting, it helps you dissolve blood clots, it has a favorable effect on fish oil metabolism, it dilates our arteries, it improves tissue oxygenation, it improves insulin sensitivity, it improves blood sugar control, it lowers lipoprotein A, and in patients with heart failure, their symptoms improve because of its anti-inflammatory effect. 20 men with stable heart failure, they're on drug therapy, their ejection fraction is 25%, they have low or low normal testosterone levels, baseline assessment, randomize them to testosterone 100 milligrams intramuscular every 2 weeks or placebo. You reevaluate it at 12 weeks, double-blind protocol. New York Heart Association functional class improves. How far you could walk, their walking distance improves 8% with placebo, 28% with testosterone. So adding testosterone to drug therapy in patients with heart failure gives you a benefit. The Minnesota heart failure score falls. The Beck depression inventory falls. Testosterone is very good for your mood. BNP, that is the lab marker of the severity of heart failure, rose with placebo therapy. It fell with testosterone. So last week we talked about drugs and devices. Tonight we talked about nutritionals. And most of the studies used one nutritional at a time, which is not the way we do it in clinical medicine. We would like to use all the nutritionals that Mother Nature intended us to take in. Now, we are starting to see some studies of combination nutritionals. Here's one, 30 patients with heart failure, mean age 75, ejection fraction below 35%, all on maximal drug therapy. You do a baseline assessment, randomize them to a multi-nutritional or placebo. You reassess at 9 months. 2 of the subjects died, but of the survivors, the need for diuretics decreased in the multivitamin group. Their heart was more efficient, they need less diuretic. The nutrient supplement, this is the particular mix they used. It has C, E, D, CoQ, B6, not everything that I'd like, but a lot of good things. It's a cocktail of antioxidants and biogenic support. And what happened, end diastolic volume, the heart when it's at rest, increased in the placebo group, and it decreased with active therapy, as did the systolic volume. The ejection fraction decreased with placebo therapy. It rose from 26 to 31% with active therapy, as you would expect. Now, I like this type of study. We're using all the nutritionals that we think are appropriate. Actually, they didn't use all of them. They used a handful of them, and they got a nice response. Quality of life improved. Combination supplementation in pump dysfunction. 41 patients scheduled for bypass. Mean age 65, ejection fraction below 40%, all on stated medical therapy. Look at pump function. Randomized to MyoVive, 250 cc's a day. That is a European nutritional supplement or placebo, and reevaluate at 5 weeks. Now, this was the cocktail they used. It had CoQ, and I think it had carnitine. It has taurine, CoQ, carnitine, taurine, a bunch of good things, some magnesium. End diastolic volume decreased 8%. It rose 10% with placebo. And systolic volume fell 5%. It rose with placebo. Ejection fraction didn't change because both of the volumes decreased in the same direction, but pump function did improve. The ultimate cardiofusion is my approach to providing you with a supplement that has all this good stuff. It drives me crazy that we have these studies that just one vitamin at a time. I think that's insane. And I want you to get all of them in a blend. So we created Ultimate Cardiofusion, which we'll talk more about next week. And this is the list of ingredients. But basically, we're covering oxidative stress, we're blocking inflammation, we're improving the endothelium, bioenergetic support, K2, which keeps calcium out of your arteries and in bones, vitamin D, etc., selenium, all the guys that I like and girls that I like. The principles of drug therapy in heart failure and post-heart attack and nutritional therapy are based upon our understanding of the causes and consequences of coronary disease, heart attack, and heart failure. If we understand the physiology, we can intervene. If we understand what's wrong, we can take corrective actions. My approach is I'm going to use diuretics judiciously to mobilize the fluid and reduce your symptoms of shortness of breath and ankle swelling, being careful not to waste potassium, magnesium, and thiamine. I will use tissue-specific ACE inhibitors, making sure I don't compromise your kidney or lower your blood pressure. I want to make room for spironolactone to retain magnesium to have an antiarrhythmic effect. I'm going to use a beta blocker to block the adrenergic whip. I use pentoxifene and lodostatin therapy to block TNF-alpha and free radical generation. I'll use external counterpulsation. I'll send you for a dual chamber pacemaker defibrillator if I think it'll be helpful. And of course, I will treat you with magnetic molecular energizer therapy if you wish. And then all my patients are recommended a broad spectrum vitamin and mineral. The team defense against oxidative stress is Mother Nature's defense that we're going to follow because she's smarter than we are. Fish oils, CoQ, carnitine, ribose, and magnesium to make ATP. Taurine to upregulate nitric oxide synthase so you have better endothelial function and to retain magnesium. Vitamin D if your levels are low, testosterone in men if your levels are low, detoxification, get the toxins out of your heart, chelation, homeopathic detoxification, the foot bath, far-infrared sauna, MME, etc. My nutritional recommendations, if you have heart failure, cardiomyopathy, or heart attack, is this long list of nutrients, and this is not an exhaustive list. To make this a little bit easier for my patients, instead of, you're going to come in with these bags full of bottles, that's a lot of work for me. So instead, we have the Ultimate Cardiofusion, 1 ounce a day, and then a low potency multi, ribose, some extra mag if you need it, testosterone in men, additional CoQ and carnitine in advanced conditions, so you can take a double dose of Ultimate Cardiofusion to cover those nutritional bases. And that concludes our 2-part presentation on optimizing patient outcome in heart failure and following heart attack. Thank you very much for your attention.